Good afternoon or morning, wherever you may be joining us from today. Thank you for being part of the 650 people that have registered to be part of Mental Health and Impaired Driving Research, Practice, and Policy, the What versus the How to Reduce Recidivism webinar. We are so excited that you all have joined us today, and we hope that you'll share this information that you learn about related to mental health and impaired driving. The National Alliance to Stop Impaired Driving, NASID, a coalition that was established by responsibility.org, is proud to offer this webinar and a series of other webinars throughout the year. And so we hope you'll continue to join us on other topics and hope you enjoy today. I'm Chris Konchak. I'll be serving as your moderator and host of today's webinar. I'm Senior Director of Traffic Safety and Government Relations for responsibility.org. And next slide, please. I'll give you a next slide. I'll give you a little background information on NASID and responsibility.org. Responsibility.org's members have invested nearly $300 million in policy development, educational programs, and public awareness campaigns to fight drunk driving and underage drinking. We work in three areas. We work to lead efforts to stop drunk driving, and then with other organizations on all forms of impaired driving. We lead efforts to eliminate underage drinking, and we empower adults to make responsible alcohol choices throughout their lives. Next slide. And NASID was a coalition that was established and led by responsibility.org, and it's working on all forms of impaired driving, especially multiple substance impaired driving. We've seen such an increase in multiple substance impaired driving throughout the country and realized that there was no one taking a real lead on this in this area. And so the organization was formed along with a lot of other great national organizations and individuals who are committed to stopping the increase in impaired driving that we are seeing related to multiple substance impaired driving. Next slide. And these are just some of the members of NASID. And then on a second slide, we'll see some of our allied members. And without any further ado, I'm going to move on and get us started on the topic that you all are really here to hear about, and that's mental health and impaired driving. We are thrilled to have three great speakers. Dr. Sarah Nelson joins us from the Cambridge Health Alliance, where she is the Director of Research in the Division of Addiction. Julie Seitz joins us from All Rise, where she is the Project Director in the Impaired Driving Solutions area. And finally, Judge Kate Huffman joins us, and she's a judge in Dayton, Ohio with the 2nd District Court of Appeals. And so each of our speakers will take you through a series of information, and I hope that in the end, you'll walk away from here with a lot of great ideas and things that you can take back to your community. I'm going to turn it over to Sarah now.
Thank you so much, Chris. Okay. So, a second, it's moved over. So I'm going to be kicking off our panel today by speaking about the role of mental health in DUI and the importance of mental health screening in DUI settings. I'm going to be throwing a lot of data your way because that's what I do. So buckle your seatbelts, but I'm also happy to share my slides and any papers with anyone who wants to take a deeper dive after this webinar. So before we get started, I want to recognize our funder for this project. So responsibility.org, otherwise known as the Foundation for Advancing Alcohol Responsibility, has provided primary and ongoing support for the development of our screening tool, CARS, for almost a decade now. And the work we've been able to complete really wouldn't be possible kind of without their support and collaboration and general patience with the academic process. The National Institute for Alcohol Abuse and Alcoholism has also funded some of our studies that I will be discussing today. So today, in talking about mental health in DUI populations, its relationship to DUI behavior and recidivism, and its importance of mental health screening in DUI settings, we need to first back up and consider more generally how mental health and addiction relate to each other. So most organizations and programs dealing with DUI have a good understanding of how impaired driving coincides with alcohol use and substance use disorders and problems, but it's important to take that consideration a step further. The co-occurrence of psychiatric and substance use disorders has quite serious implications for DUI treatment and recovery. And the more that we learn about substance use and addiction, the more the failure to address co-occurring mental health issues seems like a really missed opportunity within settings like DUI programs. So to think about this, I want to take you back to middle school math class and Venn diagrams to start. So imagine that the circle in the middle represents people with an addiction problem, or in our case, a repeat DUI offender with an alcohol use disorder. If we start looking further and assessing further, we might find that of those repeat DUI offenders with an alcohol use disorder, a significant proportion also suffers from manic episodes. We might find a proportion suffers from PTSD. Many experience depression or anxiety disorders, and others might have disorders that we haven't even assessed for. And what you're left with is a very small proportion in the middle there that actually are suffering from pure addiction without other mental health issues. So why does that matter? How does that relate to impaired driving? Well, many of you have probably seen a chart like this before. It's from NHTSA. It shows the percent of motor vehicle fatalities that are alcohol related. And the main point of this chart is that we saw major reductions in alcohol-related motor vehicle fatalities through the end of the 20th century. So you can see those lines going down. And that's potentially due to many people changing their behavior due to the information campaigns and interventions that were going around. But we also see a leveling off of that reduction. The chart seems to kind of plateau from about 2006 to 2017. And then finally, we see what might be the beginning of an increase in the last few years. So the prevalence of alcohol-related motor vehicle fatalities looks better today than it did in the 80s, but DUI continues to be a devastating problem, and the plateau is concerning. So over time, we've taken a number of different steps to reduce DUI and DUI reoffense. These include information campaigns, random roadside checkpoints, school education, licensing sanctions, vehicle sanctions, ignition interlock, etc. But when we look at the research around some of these initiatives, they aren't quite as effective as we might hope. And so in some cases, like ignition interlocks, they're very effective while they're on, but you see recidivism levels and behavior levels kind of return to non-interlock levels once they're off. And that suggests that these interventions might be serving more as Band-Aids and not addressing the problem fully. So back when we began our work, we hypothesized that DUI offenders and repeat DUI offenders in particular simply weren't getting the message. They weren't deterred in ways that other people were. And there's work that suggests that people who drink and drive frequently have just as much knowledge about DUI and its consequences as everyone else. So we hypothesized that the reason repeat DUI offenders were not getting the message was not a lack of information, but because of underlying issues that compromised their ability to change their behavior. So I want to pause for a second and have you all think about repeat DUI offenders and think about what percent of repeat DUI offenders you think have experienced and qualified for a mental health disorder in addition to alcohol use or drug use disorder. Okay, so think about that for a second, kind of get a percent in your head. So what we found in our research is that about 45% qualify for a lifetime psychiatric disorder in addition to an alcohol use disorder or a drug use disorder. And so I'm going to go into some of our research on those specific issues related to mental health and what we found. This chart shows results from one of our first studies of repeat DUI offenders. We conducted comprehensive mental health assessments with almost 800 repeat DUI offenders in an inpatient program that was part of their sentence. And then we compared those results to a national general population study that used the same assessment. So the red bars are the DUI offenders, and the yellow bars here are the general population sample. So not surprisingly, you can see that the repeat DUI sample had significantly elevated rates of alcohol use disorder and drug use disorders, but we also found significantly elevated rates of conduct disorder, bipolar disorder, post-traumatic stress disorder, and generalized anxiety. We didn't actually find a difference related to depression, but other researchers have. And overall, as I said, about half the sample qualified in their lifetime for a psychiatric disorder that was not a substance use disorder. Also, compared to the general population, we find that repeat DUI offenders are significantly more likely to suffer from more than one psychiatric disorder. So that pattern is basically the same when we look at past year prevalence. So that's whether somebody's qualified within the past year for the disorder. And we see those same patterns. More importantly, even if psychiatric comorbidity is high among DUI offenders, there's still this question of whether those mental health issues are directly linked to DUI behavior and recidivism. So in one of our studies of repeat DUI offenders, we also tracked criminal offense for 5 years using actual records. So it was 5 years after these offenders left the program they were in. This chart is comparing the number of psychiatric disorders each offender qualified for, and then whether they reoffended. So let me walk you through it. The blue line shows that most people had 1 or 2 disorders, and then that rate declines. So for example, just over 10% of the sample had 4 disorders. More importantly, the red line is showing you that as the number of disorders increases, so somebody has 3 disorders or 4 disorders, the rate of reoffense increases almost in a linear fashion here. So that's telling us that DUI offenders with greater lifetime histories of mental health problems are more likely to reoffend. Now, this chart shows, kind of from that same study, DUI offenders grouped by their past criminal history and lifetime mental health history. So not surprisingly, those with greater criminal histories and more substance use disorders, and that's the red bars in this graph, had higher recidivism rates. But what's important is that those with past mental health histories who did not have considerable criminal histories, that's the yellow bars, were also more likely to recidivate and reoffend than others. So there are 2 more findings I want to draw your attention to, and I know this is a lot of information, so we can kind of come back to this if there's time at the end, if you have any questions. But first, when we look at repeat DUI offenders, the vast majority of them are male. In the programs that we've studied, it's usually about a 70-30 split, so 70% male. But when we look at the mental health profiles of male and female repeat DUI offenders, the women who are repeat offenders have more severe mental health profiles than the men. So this chart shows that women are more likely to have 1, 2, or 3 or more mental health disorders in addition to substance or alcohol use disorder than men. The females here are the yellow bars, males are the red bars. And finally, as you would expect, repeat DUI offenders, so those who have been arrested or convicted for DUI offense more than once, are more likely to screen positive for past year mental health disorders than first-time DUI offenders. And here I put first-time in quotation marks, because this is first time arrested or convicted, and we know that people likely engaged in DUI behavior many, many times prior to their first time arrest. But in any case, a significant proportion of first-time offenders also have mental health comorbidity here, even though it's higher among repeat offenders. And that's important to consider when we're thinking about how best to target our screening. So all of this clearly calls for mental health screening among DUI populations. Our research and others have shown that mental health disorders are highly prevalent in these populations, and that there's some evidence that they influence recidivism. So the question becomes, why don't all DUI programs screen for and address these issues? And there are several barriers that we've run across to this type of screening. Awareness is one of them. So a first step is simply educating people in programs that these issues are prevalent. Training is another issue. Many DUI programs don't have clinicians available to assess for mental health problems. And I think a really large issue across programs that we've found is a lack of time and resources for screening. So in short, DUI treatment providers rarely have kind of the training or experience to identify mental health issues or the resources to do it among their clients. Enter CARS. So I'm going to briefly talk about the screening tool that we've developed at the Division on Addiction. It's called the Computerized Assessment and Referral System. And the immediate purpose is to provide counselors, court staff, intake coordinators, et cetera, at DUI programs and specialty courts with a tool that they can use to screen for mental health disorders among their clients and provide referrals for additional treatment for those issues. The tool provides user-friendly, individually targeted reports that can be shared between counselors and clients. Very briefly, it's a standardized mental health assessment that it's initially kind of adapted from, called the Composite International Diagnostic Interview. CARS screens for 17 mental health disorders. It assesses both lifetime and past year occurrence of those disorders. Currently includes both an interviewer-administered and self-administered version. Can be administered by non-clinicians, takes less than an hour to complete, and also includes questions on things like treatment, stress, domestic violence, other life experiences, and then generates an automated report that includes screening results, treatment history, risk factors, et cetera. And that report is written at a level where we would expect that it could be shared with the client and discussed with the client as well. So we can come back to this slide if there are any true data nerds in the audience. I want to just highlight a couple very minor things on this slide. This is basically showing the results from a study we did just looking at the properties of the CARS screener and kind of its psychometric properties. So first of all, almost all of the DUI offenders who screen positive for an alcohol or substance use disorder using the CARS screener qualify for that disorder if you go on to fully assess them. And between 1/3 and 2/3 of those who screen positive for other disorders go on to qualify for those disorders when you fully assess. The CARS screener has very good sensitivity, which means it catches almost everyone who has a disorder, and good specificity too, which means we are not falsely identifying too many people as having disorders. So the most frequent question I get about CARS and other mental health screening in DUI populations is where that screening fits as kind of risk needs assessment or whether it predicts recidivism. And even though CARS might do both eventually, it's important to review its primary purpose here. We know that mental health issues are associated with repeat DUI behavior. And we know that untreated mental health issues in particular reduce the effectiveness of substance use treatment. So the primary purpose of mental health screening in DUI populations is to identify those issues, to facilitate further intervention and treatment, which in turn, we hope reduce recidivism. Next question is, when should that screening occur? And I believe Julie and Judge Huffman will be talking about this, but in general, what I've found is that many months can often pass between the time an individual is sentenced and the time he or she begins a mandatory alcohol treatment program or something like that. And that window of time is potentially an opportunity for screening, assessment, and diagnosis for at-risk clients. Often there's way too much time that goes by before any of that occurs. Screening at that level also provides an opportunity to direct kind of the treatment for each offender according to kind of that unique psychological, social, those needs. We do have CARs in use with some programs pre-sentencing as well. I do want to put in one caveat here and a call for future research. So CARs and other DUI screening tools are typically face-valid instruments. That means that we are asking respondents for their self-report of their symptoms and experiences. And we know that sometimes we might need to look at more than just self-report to understand what's really going on. So I think research needs to be done on where screening is best applied within kind of the justice system pathways for impaired drivers, and looking at kind of screening at arrest or sentencing or some other place as well. And I just want to leave you with a quote by Carl Menninger that's guided our focus on screening. Treatment depends on diagnosis, and even the matter of timing is often misunderstood. One does not complete a diagnosis and then begin treatment. The diagnostic process is also the start of treatment. Diagnostic assessment is treatment. It also enables further and more specific treatment. So now I want to hand it off to my colleagues who will give you much more practical information about how to apply all of this in the real world. And so with that, I believe I'm going to be handing it off to Julie Seitz. Thank you.
Good afternoon. I have the pleasure of following up Dr. Nelson's, and I think she queued me up really, really well. Thank you, Dr. Nelson. When we talk about, now we have the data and the research, and now what do we do with that information? And so if we just want to kind of move to the next slide and the next slide. I think, following in the understanding of screening, assessment, diagnosis, and treatment, it is critical that when we think about our repeat impaired drivers and we think about the complexities of our repeat impaired drivers, we have a fundamental understanding of the process to which we create effective treatment plans, effective intervention plans. And this takes it back to the basics, having an understanding of what screening is, having an understanding of assessment. I've done a number of different trainings and different settings where people don't even always appreciate the differences between a screening and an assessment. So there are so many opportunities in our sequential intercept model where we can create opportunities for screening. So you heard Dr. Nelson talk about when to do this, often, how often to do, and often, and how that helps us create an opportunity for further assessment for more appropriate placement. So screening is a yes, no, helps us understand if we need to do further assessment. Assessment helps guide our understanding and create a diagnosis. Again, not just a one-time thing, it's an ongoing process that creates this opportunity for placement and then and level of care, which we'll talk a little bit about, and then creating that treatment plan. And what an individualized and effective treatment plan looks like is what we're going to talk about today. Next. So we heard Dr. Nelson's data on mental health, co-occurring disorders in our impaired drivers, but let's talk a little bit about what risk for DWI looks like for the folks that we're serving. They typically have prior involvement in the justice system that is specifically related to impaired driving. They also have non-DUI involvement in the justice system. There's usually prior involvement with alcohol and other substances. As we know from the data and the research, there's likely a mental health and a mood disorder. And then, one of the things that we often will be asked, like, what discerns the difference between an impaired drive impaired driver, particularly in the treatment court setting? What discerns the difference between an impaired driving court participant versus a traditional treatment court participant? And a lot of times it has a lot to do with thoughts, feelings, and behaviors, or that resistance to and that non-compliance in the justice system. So some of that antisocial thinking. Next slide, please. So we look at this through that risk need responsivity model, and it ends up, when we kind of break it down into what that looks like, it's the who, the what, and the how. We want to match the intensity of the individual's interventions to their risk of reoffending. We need to target what those criminogenic, antisocial behaviors and attitudes are, including some of those substance use disorder and criminogenic peers. And then the responsivity. I'm going to talk a lot about the responsivity component today. How do we tailor interventions to the learning style, the motivation, the culture, the demographics, and the abilities of the folks that we're serving? Next. So you say, I'm so glad you asked, Julie. We can't do it without understanding and having a fundamental understanding of what addiction is. So the American Society of Addiction Medicine, I'm hoping some of you have heard of them. They are the leading agency comprised of over 5,000 medical professionals who specifically work in addiction medicine. And in 2019, they updated their definition of addiction to identify it as a treatable chronic medical disease that has these complex interactions between brain circuitry, genetics, the environment, and a person's lived experience. And I want us to kind of hang on to that for a moment, because that's going to be very relevant when we think about the how. How do we create effective treatment plans? And then the other part of all that is really appreciating that people with addiction and substance use disorders engage in these behaviors that become compulsive, meaning it's really difficult to stop and often will continue despite the harmful consequences. Next slide. So now that we have a basic understanding, or at least a definition of addiction, we have to appreciate what does that mean when it comes to creating treatment plans. And at the end of the day, if you've ever seen me speak, or if this is your first time, I'm going to tell you, client-centered matters. And that can be very, very difficult in some of the settings that we work in. From a whether it's the number of people we're serving, whether it's the perspectives in which we're engaging in our interventions. So what I am going to do is really help us appreciate what it means to be client-centered in a system to create lasting change. So client-centered really is assessing that not only the risk, needs, and strengths and skills that we're looking at for a treatment plan be assessed and determined, but we also have to be matching what that looks like through the patient's lens. So I like to kind of correlate what the data, the research, and our practices state in regards and correlate it to some of those examples out in the community that we might be more familiar with. And so what this is really telling us is that, yes, we need to understand risk, and we need to know what their strengths and their skill sets are, and we need to appreciate the complexities of all that. But we also have to listen to the client's perspective, or the participant's perspective, or whoever's in front of us perspective, because the more we can match and interpret it through that client lens, the more likely we are to intrinsically motivate and intrinsically understand how change happens for the person in front of us and create the lasting change. I know it's really hard in this particular setting, but I'd like you to think a little bit about, have you ever met or known someone that has done exactly what they're supposed to do based on their checkoff list? And at the end of it, the checkoff list is completed and they return to some of those previous behaviors, or even have reoffenses. Yep, I suspect all of us have raised our hand in that. And part of that can, and not all of it, but part of that can really rely on not having individualized plans that are intrinsically motivated through the client lens. So let's go to the next slide and talk about what that looks like a little bit more. So when we look at the co-occurring disorders, like, we recognize that, we've often said this, Chris mentioned I work for Impaired Driving Solutions, a division of All Rise. And so we've been working in impaired driving courts and DWI courts for well over a decade, where We have been talking through this lens for a while that if you are a treatment court, you are likely a co-occurring disorder court, right? And so really recognizing the prevalence of co-occurring disorders, but now what do we do to create an effective treatment plan for that? And I got to tell you, it's recognizing that this is a complex issue and that it's not a one-size-fits-all approach. There are varied levels of care, there are varied levels of services. And so when we think about that, it can get very overwhelming. It can become very complex quite quickly. I'm gonna calm some of that down and help us appreciate that this is just opportunity for us to ensure clients, participants, folks are getting the services that they need, including behavioral therapies, including medications, and having that comprehensive wraparound approach. Next slide, please. But one of my favorite things to say is, spoiler alert, some of the treatment works for some of the people some of the time. And so there is no single treatment that is effective for everyone. And for the sake of time today, I won't go into a lot of the detail of this, but I hope you can appreciate that research, meta-analysis has shown us for decades that there are literally hundreds of evidence-based practices for substance use and co-occurring disorders. Literally hundreds of evidence-based practices for that. And the point, when we get into all of this, is there is no single effect. There is no single treatment that is effective for everybody. Why is this relevant in this particular setting? We have a lot of programs and states and jurisdictions that say you have to do this in order to do this in order to do this. And then are often surprised when the outcomes are not as favorable or positive as they were hoping. And a lot of that has to do with not recognizing that this particular intervention may not be effective for this individual at this time. Other things about effective treatment: it needs to be readily available. It needs to be multidimensional. I have a whole session on understanding the ASAM patient placement criteria. When we talk about multidimensional, not only are we talking about ASAM patient placement criteria, but we are looking at a client holistically through the lens of their lived experience, through all of their needs, including what recovery capital that they already present with or what they may have needs for. Program length is another thing I'd like to talk a lot about, because and I say this wherever I go, but what other chronic illness do we expect to be treated in 28 days? I live in northern Minnesota, where it's over 10 degrees today, whoopee, and we are the land of 10,000 treatment centers. And I say that with respect. Some of the very foundations of what we know in our professional capacity for substance use disorder treatments was founded in Minnesota. So it's a pretty proud and long history of treatment centers in Minnesota. But I will also say, one of the things that has come out of all of this, and this is more complex, I appreciate this, when we come to payer-driven systems and legislative and regulatory requirements, but a lot of times we have program lengths that determine how long someone's going to be in treatment, as opposed to symptom reduction, symptom alleviation, or symptom needs. And so we tend to treat substance use disorders quite differently than we do other chronic illnesses like diabetes, hypertension, or even a mental health disorder. We have very fixed lengths of stay, with very determined modules, manuals, and interventions. What I can tell you is that research shows that when we have those fixed lengths of stays and we have these program-driven versus need or symptom-driven treatment planning, we tend to miss the needs and not have the outcomes that we want for our participants and our clients. So just something to think about, noodle on. One of my most favorite topics to talk about. And then we also have to appreciate that for treatment to be effective, we are continually assessing and adjusting the treatment plans to the needs. And I think that that's sometimes where we can get off base from, either in a treatment setting or even from whatever kind of lens that we might be looking at this through, whether it's through our jurisdictions or treatment courts, where we think this is the treatment plan, stay the course. And if we aren't staying said course, somehow we're off, whereby it really is making those adjustments to the treatment plans to the needs of the client. Next slide, please. So we're going to shift to this recovery management model. We think about this, the acute care model. Again, there is no other chronic illness that I know that gets treated in 28 days or 6 weeks or whatever, or a certain number of, sessions. So we really want to shift to a chronic care approach. And when I say chronic care approach, I mean, this is my utopian world where we're truly integrated with where substance use disorder treatment is truly integrated into mental health and the medical model of care, meaning it shouldn't be difficult for me to continue with my care provider. I should be able to have ongoing access to manage my symptoms before it becomes a crisis, and having ongoing care for preventative care measures too, right? So we're shifting from that acute care model to a more chronic condition approach, shifting from professional-centered, I'm big, you're small, I know, you don't, to a client-directed management of long-term recovery, putting some of the onerous and listening to what clients already have and what they need for their recovery. And so really just kind of creating this opportunity for ongoing care and what we call recovery checkups. Next slide, please. When we do this, ideally, this is from my friend and colleague, Dr. David Mealy. I think one of the things that he's helped us truly appreciate and understand is the difference between compliance and adherence. They are not the same. While we appreciate compliance, check off the list, all the things you need to do and where you need to be. And we need a level of compliance, particularly in our treatment courts and in other settings. They are not the same. And so a lot of times we will find, particularly when it comes to treatment, clients get really, really good at compliance. They know how to say what they need to say and check off what they need to check off. How many of you have ever heard a client say, I only have 8 hours left of treatment. I only have 6 hours or 2 sessions or whatever it might, 1 module. And when we think about it through that lens, well, that may be entirely true, but if oversimplified, thinking about it through only that lens, that's just checking off the box, as opposed to how are the interventions engaging the motivation, the insight, and the skill building to be lasting after we are long out of their lives. So when we look at what successful recovery and genuine adherence looks like, it's moving from this external motivation to what is intrinsically motivating clients so that they can do this long after we're out of their lives. Next slide. When I first started in this field, I was given a canned and predetermined. First of all, everybody had the same treatment plan, and second of all, it was a first and second time impaired driving or DWI level education group that we had to do for folks that were justice involved. And so clients would come in and they would say, I don't think I have a problem. Thanks for asking. I don't really understand why people are making me do this. And I got to tell you, this is what it felt like a lot, right? And so when I, in Minnesota, and I think this is in other states, but in Minnesota years ago, they would come to me with a piece of paper that said, especially if they had a second DWI offense conviction. Our court systems in DMV and Minnesota are separate, and they'd come with their little slip of paper that said in order to get their driver's license back, they had to complete 24 hours of relapse prevention treatment or 48 hours of IOP. Now, mind you, this is without a clinical evaluation, screening, assessment, nothing from a professional in an addictions field or has done any kind of evaluation. So when clients would come to me and we do an evaluation, either what would happen if they didn't meet criteria? Well, then they shouldn't even be in the program. Or what if they meet criteria for something entirely different that's on this slip of paper? What do you suppose they were asking for? I'll just take the 24 hours. Thanks for asking. Can I do it in a weekend even? And so it became this this pull, so to speak, of how do you engage with clients when all they want to do is complete from a compliance perspective, which I can appreciate. So when we think about that and we think about that compliance lens, it really is about shifting that way of thinking. And there's going to be some larger systems changes that we have to look at too. We worked in Minnesota to get that all changed, and it's no longer that way. So I feel good about that. But next slide, please. So in order for us to have effective treatment, we really have to appreciate stages of change. Now, given I have very little time today, I just have to really help you appreciate that stage of change helps us determine what intervention, and I mean that, what intervention is appropriate for the person at the time. So if someone's in a pre-contemplative stage of change, doesn't think they have a problem, I have to do, exploratory work with them as a clinician to help them understand, gain insight, gain motivation, gain some skill sets in order to be able to do certain interventions. So stage of change is critical when it comes to applying clinical interventions. And if you want to know more about that, we can certainly I have lots of opportunities to connect with y'all, but it is absolutely critical that we understand stage of change, implications of what our interventions are, and that they are matching a client stage of change. If my intervention doesn't match a client stage of change, I'm likely to get compliance, or I risk negative to null outcomes or dropout. Next slide, please. So treatment outcomes, I mean, I think we should be measuring our treatment outcomes. I think we should be, engaging and understanding what our outcomes are. When we look at it, in general, treatment in and of itself, it is fairly effective, just like any other treatment that would be for diabetes, hypertension, asthma, that kind of thing. When people are prior to treatment, their symptoms tend to be higher. When they're in treatment, their symptoms tend to be lower. And after treatment or post-treatment, symptoms tend to return to some extent, but typically lower than pre-treatment. Very similar to other chronic illnesses. Next slide, please. But what we have to be appreciative is how change genuinely happens. And what that means is, like, it isn't necessarily, if anybody remembers, Dr. Nelson's brought us back to high school. I'm going to bring us back to later high school, maybe even college, when we're in our stats class with the bell curve. And we appreciate the effect size of a specific intervention and how it relates to outcomes. And so when you look at this is out of Dr. Miller, Dr. Hubble, and Dr. Duncan's work in what works in therapy. And they talk a lot about, hey, we can appreciate what the treatment differences are. We can appreciate the specific ingredients, adherence to the protocol or the manual or whatever it might be, or even the competence of the therapist. But where change really happens is in that alliance, that therapeutic alliance, the relationship that is happening with the client and the therapist. And so that equates to understanding empathy, their positive regard and affirmation, and validating where the client is coming from, and having a general or a genuine congruence with what they want to work on. Next slide, please. So what does this all mean? It takes time. I mean, that's the other part of all this, is that we have these expectations. Some of us, not all of us, have expectations of how change is supposed to happen. Again, what other chronic illness do we expect to be treated in 28 days and with only one treatment, right? So more than half the individuals that go through treatment for substance use disorders need multiple episodes. And the progress isn't linear. It isn't this straight shot. It is often cyclic, with reoccurrence and periods of abstinence and periods of treatment. Next slide. By some estimates, and I have some amazing research on this if you want it, it takes 8 to 9 years for individuals to reach full recovery, and about 3 to 4 treatment episodes. This is from William White, one of the leading researchers on long-term outcomes of recovery and recovery management. And so people tend to go oh, geez. And my response to that is, a lot of chronic illnesses take years to reach full recovery. Cancer, diabetes, hypertension can take years for full recovery. However, that progress is still marked, right? And as and often engaged in treatment. So people, particularly in the treatment court world, are like, goodness, what are we supposed to do in the 12 to 18 months? We are laying the foundation and the groundwork for those long-term recovery outcomes. Next slide, please. And so, appreciating our safe system approach, you know, this is one of NHTSA's countermeasures to repeat or impaired driving, is making sure that we have access to these services. Next slide, please. So through this lens, we're looking through the kind of like appreciating the non-linear approach, but appreciating that not only the timelines that are involved in all this, but the different levels of services. So we have pre-recovery, we have in-treatment, and then post-treatment recovery supports. Next slide. Change happens. This is Carl Rogers, old school, when people have compassion, empathy, and acceptance. And I know, and I'm not naive to the crowds and the audience that we might be speaking to. And I'm Judge Huffman's going to talk a lot about where the balance of this with the accountability of the courts comes into play. And I don't want to dismiss the brevity and the importance of keeping our communities safe. I'm talking through the clinical lens. So we have this combined lens of understanding change happens in effective treatment when people are met with compassion, empathy, and acceptance. Next slide, please. And then it starts to feel a little bit like this. We're walking on the same path and creating a treatment plan together. Next slide. And I like to end most of my sessions with, until lions have their historians, tales of hunting always glorify the hunter. I've sat around a lot of clinical supervision and treatment court tables where when clients are doing what we need them to do, we're patting ourselves on the back and saying they're following our treatment plan. And when they're not, we tend to put all the onus and the blame on the client. And again, I want us to really appreciate that sometimes for treatment, it may be an ineffective intervention that we're engaging the client in, or a not matched intervention, or an alliance mismatch. And so we have to be willing to look at just what effective treatment looks like to create these engaged, better outcomed programs. So with that, Judge Huffman's going to talk a lot about how we bring it all together.
Thanks, Julie. You know, Julie, kind of that, I like the way she ended, because she set me up in the sense that how do we take the research, the clinical findings, and apply that in a setting where we expect compliance. Next slide, please. So how do we address mental health concerns in the courtroom? Applying that research, applying the clinical information, and remembering that particularly whether it's traffic court or any court is extremely busy. Nobody comes in front of a judge or a law enforcement officer or a probation officer or even the prosecutor or the defense attorney with a sign around their neck that says, my issue is blank, whether it is mental health issues, substance use, etc. And so it is for us as a legal system to slow down, in some respects, stop expecting compliance without the court doing what is necessary to determine what the individual's needs are, risks, etc. So before I go any further, I do want to say that I spent 21 years in a trial court. Like those of you who are on this webinar who work in the court system, I think I've seen just about everything. I have the privilege of working with about 38 other judges around the country as judicial outreach liaisons. Our roles are to provide education for judges and those involved in the judicial system, working in the judicial system, on evidence-based practices in impaired driving. If you'd like more information about that, my contact information will be at the end. Next slide, please. So let's look at a typical scenario. Let's assume you have a driver that's arrested with a 0.1 BAC. A year later, he appears in court for a plea, and the judge says, you know, I'm going to require you to have a drug and alcohol assessment before sentencing. This is very typical. And the driver is not happy. He says, look, this is not my problem. You know, it was the cop. I'm not doing an assessment. I need to go back to work. And as Judge Nelson, or excuse me, as Dr. Nelson said, there's often a disconnect between the time of the offense and the eventual, whether it's the screening and assessment or the sentence or the consequence. And so, let's take a look, and what we're going to do from here on out is to talk about some things that courts need to understand, need to appreciate in their processing of impaired driving cases, and then their reaction to their clients. Next slide, please. So the very first thing that is important is we have to stop assuming that an arrest for a first offense is really a first offense. The data is daunting, in my opinion. In 2020, there were about 1 million, slightly more than 1 million drivers arrested for DUI, but there were 127 million impaired driving episodes. Now, I'm not good at math, but that's less than 1% of the episodes of impaired driving result in an opportunity for intervention, whether that intervention is by the court, the intervention is by some other individual, whether it's family members, social services, et cetera, to get involved with that individual who is engaged in very risky behavior. In addition, there's other data about how often an individual has gotten behind the wheel of a car and driven impaired before first arrest. Some conservative data by the FBI is 80 times before the first arrest they've driven impaired, and again, then imperiled themselves and others on the roadway. There is other data that suggests that number of times they've driven impaired before first arrest is much higher. So we can't assume that somebody who appears in court with a first conviction for impaired driving is a first offender. We have to stop treating them like this is just, they just had bad luck and got arrested for the first time. Next slide, please. We have to stop making those assumptions. We must start intervening earlier. And you're all probably familiar with the sequential intercept model that tells us that we can intervene to assist people with a variety of concerns, including mental health and substance use concerns, long before they ever come to court. We can do that whether it's roadside. You can find a partner to work with that can assist courts with early intervention. I'd like to tell you about an Ohio State. I live in Ohio, and there's an Ohio State Highway Patrol program that I think is incredible. It's early on, so there isn't a lot of data. But upon arrest for any impaired driving offense, the Ohio State Highway Patrol sends all of the information, name, phone number, address of the individual who's been arrested, even if they weren't, didn't go to jail, even if they were released roadside to someone, to all the social service, treatment, behavioral health organizations in that community, so that those organizations can attempt to make contact and encourage treatment long before the individual's ever gone to court. Those contacts may include a phone call. They may include a peer support showing up at home. They could include something that's emailed or mailed to the address. But the effort is, if we can get that early contact closer to the time of the event, the arrest, rather than waiting potentially a year for disposition, we may be more effective in our interventions. Next slide, please. So, how can courts identify those with mental health concerns who are, are impaired, they've been arrested for impaired driving or also for some other offense? Well, next slide, please. We can require universal screening and assessment. And Julie has talked with you about the difference between screening and assessment. But if we've done a screening and that screening demonstrates that we are in need of assessment, we must go on and do that assessment. We are looking for typically high risk, high need individuals who are most in need of intervention. And as Dr. Nelson talked about some of the screening tools that are available. But what I would like to emphasize here is while we should require universal screening and assessment, we should be using the right screening and assessment tools. You may live in a jurisdiction where a particular screening and assessment tool is required. However, that tool may not be validated for impaired drivers. It may not, I'm probably using the wrong term, but it may not be appropriately validated for mental health concerns. So make certain you are using the right screening and assessment tool. Just as an aside, for impaired drivers typically, will screen low risk, low need on a traditional screening and assessment tool. But with a validated impaired driving assessment, it may very well reveal high risk and high need. So use the right tool and make certain it's universal. Everyone is screened and assessed. Next slide, please. And Julie suggested this, don't just screen once. Screening may be required on multiple occasions. Because again, as Julie discussed, the stages of change, it's not linear. We don't go up the stages of change, start at pre-contemplation and move neatly up these up the steps to maintenance or recovery, whatever term you want to use. Individuals cycle through those stages of change. They may go up and down the stages of change. And so we can't assume if we did a screening and assessment and somebody is in the preparatory stage of change, that they're then going to proceed up that ladder. We must make certain at all times that we are providing the right amount of treatment, the right type of treatment, et cetera. Julie taught me this phrase, we got to sprinkle on the right amount. And if we're not doing screening and assessment often, we don't know if we're giving them what they need. Next slide, please. Now, I mentioned at the beginning, you know, if we've got a year between the time that an event, the arrest occurs and disposition, you know, is that individual motivated to now make change or be involved in treatment? And there are a lot of disincentives for an impaired driver to proceed rapidly with their case. Oftentimes, there's either mandatory jail or a fine or a license suspension that driver understandably wants to avoid, just want to kind of move that down the line to a different place in time. But we are not helping as a system if we are slow walking impaired driving cases, because the research is that impaired drivers don't believe they're criminal. And I'm not trying to label impaired drivers as criminals, but they don't believe their behavior is criminal. Why? Because it is prevalent. Drinking is highly accepted in our society. And so there is, again, that disconnect. So as much as possible, moving an impaired driving case through the court system actually is going to help that individual. Next slide, please. All right, but what we want to slow down about is we want to take the time to find out information about that driver, whether it is their assessment, what resources are available, what are their individual circumstances. So while we want to have a disposition earlier, we do want to take the time to get all the information that is needed about that individual. Next slide, please. You know, Julie mentioned, how do you define success? Is it compliance? You know, we often overlook mental health concerns in the courtroom because we're focused on compliance. Did the individual check the box? Did they go to their treatment this week? Did they meet with their probation officer? Are they following the other sanctions that are required? When compliance is not necessarily equal to success. Next slide, please. And so to avoid assuming that compliance equals success, we want to recognize that one size does not fit all for impaired drivers, as it doesn't fit for any criminal offender. We have to take the time to figure out what is needed by that individual. And how can we do that? Next slide. We can practice individualized sentencing that incorporates, again, as Julie had mentioned, the risk needs responsivity model. We want to look at an individual's risk. What are their criminogenic risks? Because not every risk is criminogenic or crime affecting. We want to look at their criminogenic needs, because once again, not every need an individual has is related to criminogenic behavior. And then we want to look at their individual responsivity. How does that person need, what do they need in terms of how their services are provided? So, for example, some people are visual learners. Maybe, you know, they may need a different type of treatment sort of vehicle than other individuals. So what is that individual person's risk, need, and responsivity? Because again, one size does not fit all. Next slide. As a final note, I'd like to talk about a circumstance I had when I had a women's treatment court with a DUI tract. We had an individual, 36 years old, 3 children. In her case, she was their sole caregiver. She had already been to prison for a felony DUI offense. She was now on her 3rd felony. She was compliant, always very pleasant, checked every box, showed up on time, no concerns. But we were in treatment team one day, and her treatment provider said, you know, I've been providing her treatment for a long time, and I'm really worried because when she hits that 6-month mark in her recovery, she does something to sabotage herself. What are we going to do? How can we prevent that this time? Well, unfortunately, we didn't, because about a week after this conversation in treatment team, Betty went out and with an old boyfriend, went to a bar, became intoxicated, drove, and was arrested for her 4th felony. While she was involved in that 4th case, which I didn't have, I only had her treatment court case, she finally revealed some trauma. And if you'll move on to the next slide. And Dr. Nelson and Julie and I have given this presentation before, and I said then, and I'll say it again now, we failed her. As a system, we failed her because we never explored trauma. This is now her 4th felony DUI, which meant she had at least 3 misdemeanors. She's 36 years old. And because she was so compliant, checked every box every time, we didn't dig deeper. And so I guess my reminder from this circumstance is that don't assume compliance means there isn't something more that needs to be addressed, and it may very well be trauma. Thank you, and I'll turn it back over to Chris.
Thank you. Thank you all so much for joining us today to learn about this important topic. We hope that you'll check back in with us if you have questions. We'll be sending out an email that will include a link to the webinar if you want to watch it again or share it with others. We'll also have our position paper from responsibility.org on screening and assessment. And we will have some additional information that Dr. Nelson has included with links to CARS and some other research that they've done and things like that. So we are happy to be of service to everyone on the call and figure out how we can connect you with resources in your communities, help you address mental health and impaired driving wherever you may be. Hope that you'll check back at responsibility.org and NASID.org for additional information and upcoming events and trainings and things like that. Again, thank you to Dr. Nelson, to Julie Seitz, and to Judge Huffman for leading this incredible webinar today and providing all this great information. I know that there were a few questions in the question and answer box, and we'll try to get back to you if you left a name with it. If not, if you want to email me, I'm happy to pass that along to whoever may be able to answer those questions, and we'll get back to you. Thanks again. Hope everyone has a wonderful day.